Hello friends, today I'll be showing SICS in a one-eyed patient. This was a hard brown to black cataract with semi-dilated pupil and corneal degeneration, which you can see is visible now. And these are the cases when one lands up in complication, and these patients have weak zonules. So one has to be very careful in dealing with such cataracts, and being undilated, it is really tough in such patients to have an adequate size RHEXIS since the size of nucleus is big, and these patients have an high expectations from the surgery as being one-eyed. So let's see each step of the surgery one by one. Initially, conjunctival flap was raised. I always try to create a small flap so it becomes easy with the one tooth forceps to hold that flap. One should do minimal cautery, and all the bleeding points should be cauterized. And once cautery is done, then you have a clear scleral bed to make your tunnel. Cautery is advised to prevent any intra-op and post-op hyphema. Then when 15 number blade, a frown incision was made. Then with the help of crescent blade, I usually create that depth, and once I feel that I have created an adequate depth, I enter the tunnel at one point. I go straight inside the cornea and then sweep my crescent blade sideways. This gives you an advantage in case you land up with a superficial buttonholing or a premature entry, then probably you can leave that point and start your tunnel from another point, and then you can extend that tunnel again sideways. After making an adequate tunnel, the entry was made with a 3.2 keratome, and as you can see, the pupil size has gone smaller. So the now real challenge is to make RHEXIS, which I feel that while you are trained with Utrata's forceps for making RHEXIS, you can easily make an RHEXIS using Utrata's forceps. While making RHEXIS, there should be few points in your mind that you have to create a larger RHEXIS because the nucleus is of a bigger size, and your movements are probably the same as you make in a dilated RHEXIS. The only difference in this RHEXIS is that you cannot hold the RHEXIS from the base because base is beneath the undilated pupil, but you should have that same movement, and you should be gentle at any point of time. You should not pull the RHEXIS, and at any point you feel that you cannot move the flap freely, then probably that is the point when it has extended to the periphery. And if you can move freely the flap all through 360 degrees, then probably you are moving your RHEXIS in the right direction. And see, I was able to complete my RHEXIS. Pupil is still very small. Now after doing hydro, I rotate my nucleus, and that is a large nucleus, and while rotating I try to lift it into the NTA chamber, and as you can see I could prolapse one of the pole of the nucleus into the NTA chamber. So that means my RHEXIS was of adequate size. I inject visco beneath the nucleus, and in SICS I generally do a delivery while my nucleus is still half in the bag and half is prolapsed in the anterior chamber. The only precaution you have to take, you have to instill a lot of visco beneath the nucleus so that the PC is pushed back. And while I was going in for the very first time, I felt some resistance. I went in, dialed the nucleus again, instilled some more visco, and then I went with my irrigating vectis again beneath the nucleus. And as you can see, now I'll enter the anterior chamber, my vectis is beneath the nucleus, and gently I bring that piece of nucleus out. Then with irrigating vectis, I depress the posterior lip a little, and I inject the fluid with the help of irrigating vectis itself, and leftover cortex is expelled out by depressing the posterior lip. Now the nucleus was out, and you can see there are some cortical material left. Always use Simcoe cannula to aspirate those cortical pieces which are left from the side port, as then your AC is well formed and there is a minimal risk that you will catch the posterior capsule. But in this case, after delivering the nucleus, the iris became a little bit floppy, and I had some struggle managing the iris, which was prolapsing through the side port and even through the main port. As you can see, that some iris is now troubling me, and there was now some amount of thrust also. So I was quite careful at this stage because the most of the steps of surgery was done, and now I was almost towards the end of the surgery, and any minor mistake or any mishandling at this point could have created a rent. So in this case, you should be very alert, use lot of visco, always try to push PC behind, deepen your anterior chamber, and be very careful while aspirating the cortex. Only that cortex which is beneath the side port should be aspirated through the main incision. Otherwise, one should try and aspirate all the cortex from the side port as much as possible. Since when you go in through the main incision, again there is a risk that AC might get shallow, and as you can see that iris is troubling a lot, and since this was a one-eyed patient and there was now lot of thrust, and after aspirating all the cortex, the IOL was implanted in the bag. Inject visco to protect the endothelium, and then through side port with the help of dialer, the IOL was deposited inside the bag. Foldable IOLs, they have one advantage over the rigid IOLs. Like if your RHEXIS is intact, the foldable IOLs can easily be implanted in the bag. And now the case was almost done. The IOL was implanted in the bag. Since iris was floppy and coming out of the port, so I injected air in the anterior chamber at the end of the surgery. And for beginners, if they are in doubt whether their tunnel is appropriate or not, one should try and instill air bubble at the end of the surgery and see by little depressing if it leaks out or not. Because in case you have a leaky tunnel, then when you press and when you check for the tone of the eye, you always find that air bubble will leak out from the main incision, and even when you are injecting, still then the air bubble will leak from the leaky wound. Now the case was completed successfully, and thank you for watching this video.